Okay, today we're going to be talking, have 15 minutes. This is a 1-hour lecture, but I try to concise it as much as I can. We're going to be talking about medical treatment and particularly oncological treatments of GE junction. Outlines, we'll mention a few words about immunotherapy. We'll talk about localized and locally advanced GE junction. And then we'll talk about localized and locally advanced gastric cancer, as Dr. Remy mentioned to you the difference. And after that, we'll talk about molecular testing and what's advances in treatment of metastatic GE and gastric carcinoma. A couple of words about mismatch repair, PD-L1, CPS score, and at the end of the lecture, I'll be talking about a couple of studies related to HER2 and Claudine 18.2, which is a new kid around the block. Now, just to refresh your memories, we have your immune system usually attacks any abnormal cell. T cell tries to recognize these tumor cells, which is in the bottom. Up. Where's the pointer? Yes. Okay. And here, through direct interaction with the T cell, induces cytotoxic effect on the tumor cells. Came about having two receptors. One of them is called PD-1 receptor, PD-L1 receptor. On the side of the tumor cells, you have the PD-1 and PD-L1, and the T cell is a PD-1. Everybody is familiar with nivolumab, which is called Opdivo, and pembrolizumab, which is called Keytruda, at the side of the T cell, and the atezolizumab, avelumab, and durvalumab, which are PD-L1 inhibitor, at the side of the tumor cells. What happens is when you stimulate this receptor, it basically allows the T cell activation and increase the T cell cytotoxic function and induces tumor apoptosis. Another important receptor that came about is CTLA4 receptor, and we have a medication to target this receptor, such as belimumab, short for AP or Evroy, and there's another drug, it's called tremelimumab, short for Tremi. Similarly, it activates the receptor and it uses cytotoxic effect with the T cell, which is your immune system, affecting and tumor cells and induces killing. Now, everybody heard about PD-L1 and PD-L1 CPS score. And what is it basically? It's a combination, positive score, and these scores are basically tumor cells, lymphocytes, and macrophages are divided by total viable tumor cell divided by 100. And in your right side, you have the positive PDL score, which is mentioned here. And in your left side is a negative PDL score. Why is that important? It's important because the higher the score, the better response to such therapy. Now we'll go into the topic, talk about localized and locally advanced tumor. It has noticed that if you give neo-adjuvant chemotherapy compared to surgery alone, it has a positive result and have better response rate. What's neo-adjuvant means? Neo-adjuvant means a treatment before the surgery, and adjuvant means treatment after the surgery. So neo-adjuvant means before, adjuvant means after, for the one who doesn't know. And following that, a cross study was designed, and it was prepared in such a way where to give 1 day of chemotherapy, which is here mentioned in the one day of chemotherapy on day 1, and day 1 through day 5, we give radiation therapy. And this is a program for 5 weeks program, and utilizing carboplatin and Taxol in the lower dosage. And this study showed a very positive results, almost doubling the survival rate from 24 months to 48 months, almost doubled. So that actually created a big rush in the oncological community, and everybody started using this regimen. Particularly the one who benefited the most is the one with the squamous cell histology. Maybe I use this as better, that's okay. Now, for the patient who received cross trial and they went through the chemo and radiation, and then after that they had the surgery done, if they have any residual disease, these patients were randomized to receive immunotherapy with nivolumab versus observation, which was a standard of care at that time. And it was a big surprise to us that we found that even the patients, after having their surgical resection and went through the cross trial, they still have some residual disease, they benefited from immunotherapy. And little by little, the role of immunotherapy started to be more recognized over time. And again, the one who carried PDL score, CPS score, higher score, the better results, and the squamous cell morphology benefited the most. Not to mention that adenocarcinoma histology also benefited. Now, so in summary, locally advanced esophageal carcinoma, neo-adjuvant means before surgery, platinum-based chemotherapy, especially with carboplatin and Taxol, offers survival advantage with better local control, but some increase in surgical morbidity. Now, 1 year of adjuvant nivolumab significantly improves disease-free survival in patients with residual disease on resection, especially in squamous cell histology and CPS score of more than 5 with lower T stage. So overall survival expected to follow, and but the results are still pending. Now we're going to switch gear. We're going to go to the gastric carcinoma, and I'm going to present to you the trial starting from the original trials that initially randomized patient to upfront surgery followed by observation versus chemo, radiation chemo. And this is protocol 0116. We used that about 15, 20 years ago. And it was, again, it made a big loud noise at that time. And a patient who had muscle invasion or lymph node involvement, and they have about 9 to 10% improvement in survival. Following that, we have the MAGIC trial, which divided the patient to chemosurgery, chemo versus surgery alone. And again, it was a significantly positive trial. Please note here that the chemotherapy regimen, we used ECF regimen, which is ibirubicin, cisplatin, and 5-FU. Now, 5-FU was given for 21 days, which is a little bit cumbersome. To give the patient continuous infusion sometimes requires hospital admission. It was a little bit inconvenient. Now, with this MAGIC trial, it was about 13% in 5-year improvement in overall survival. So again, this was a positive trial. Now, European Community Oncology Group sponsored the FLOOD trial, and what FLOOD goes 5-FU, leucovorin, platinum, and taxotere, and this compared to the ECF regimen, which given once every 2 weeks instead of giving it for 21 days continuous infusion. And to our surprise, this study was also positive. It was originally designed to non-inferiority, but it came back superior to the EPF regimen. Therefore, to ECF regimen. Therefore, now that doesn't come without side effects. There are more side effects with the continuous infusion, and this has more myelotoxicity. Now, in conclusion, locally advanced gastric carcinoma. So again, post-operative 5-FU-based chemoradiation therapy remains one of the standard of care for muscle invasion and lymph nodes involvement. Now, the MAGIC trial, as I mentioned, pre-operative, neo-adjuvant, and post-operative ECF regimen improved survival. And lastly, the FLOOD regimen showed a better response rate and better overall survival compared to the ECF regimen. Now, for some patients who cannot tolerate taxotere, because this is a little bit myelosuppressive, so we can use FOLFOX regimen, which omitting 5-FU. Now we're going to move to the molecular testing. Okay, mismatch repair testing in all GI cancers. Again, this is created a big loud in the community because this was positive trial using pembrolizumab, which is Keytruda, and again, it shows a significant effect. You keep hearing in the news about this. Immunotherapy has cured some of the GI malignancy, and it's true. It does have a very good effect against these mismatch repair genes. Now, coming back to the CPS score, which is the PD-L1 positive GE and gastric cancer, I'm going to present you two studies really quick, which is short at a time, Checkmate 649 and Keynote 590 using nivolumab, which is Opdivo, and pembrolizumab, which is Keytruda. Okay, now here we have chemo and immuno combined versus chemo alone, which is what the standard of care. And this is the results. Again, positive score, more than 5% showed a significant improvement in overall survival. Similarly, anytime you see a checkmate study, which is Opdivo, at the same time you see pembrolizumab, which is a keynote. So they are in competition between Keytruda and Opdivo. So this is the Keytruda pembrolizumab, similar design, but at this particular study, they use CPS score of 10 instead of CPS score of 5. And again, similarly, it has positive results. And now it's becoming a standard for our community to use the chemo plus immuno. Unfortunately, in Lebanon, we have some difficulty getting some of the medication, but this is a positive trial, and particularly the one who have squamous cell histology, as you can see here. Now, we talked about mismatch repair. We talked about CPS score. We presented you two trials. I'm going to shift gears and going to the HER2 positive. Now, the previous one that we mentioned to you here, they were non-expressive HER2. If they do express HER2, these tumors are more aggressive, and they need some sort of targeted therapy to control this disease. Now, Stogat's trial, which was positive trial by adding trastuzumab, which is anti-HER2 antibody, and came back with positive trial compared to chemo alone, and this has become the standard of care. Now, if you add immunotherapy to trastuzumab, the waterfall chart, you can see that increased the effectiveness of the treatments with HER2 treatments. Now, I'm going to introduce to you a new concept, and please pay attention here. Has made also another revolution in the oncology community and the treatment of not only gastric carcinoma, but also in the treatment of a lot of other diseases, such as in the one on the breast and others. So what basically the antibody drug conjugate means, you have an antibody that with a linker to a payload. And this payload basically is a chemotherapy. And you deliver this antibodies against this receptor. We're targeting the tumor cells and then delivering basically the payload. And as soon as they introduce to the cell, the linker dissolve and induces cytotoxic effect.
Sorry, Dr. Matar, 2 minutes? 2 minutes.
I'm almost done. So this is the mechanism and how this drug introduced to the cell, and it does have some bystander effect. Using this drug, actually with Destiny trial, it does show improvement in response rate and also improvement in overall survival with a p-value of 0.0051, which is really significant at this point. So now, please note that these patients already receive Herceptin. So this is a very, very good and very powerful drug. Not only anti-HER2 used for the GE junction and gastric, it's also used for breast and some other minority of other diseases. Finally, I'm going to talk about Claudine 18.2, which is a new kid around the block. And this Claudine 18.2, this medication has not been yet approved by the FDA, but this is the newest available information about this drug. Basically, what's Claudine 18 is a protein that in human encodes for Claudine 18 gene and belongs to the Claudine. Basically, it keeps these tight junctions together, and attacking this tight junction, it separates the tumor from itself and induces apoptosis. Zolbetuximab has been again reviewed by FDA and has not yet got the approval as of yet, but I think they will get it approved soon. And it attacks Claudine 18 And the trial that was done about this presented in ESMO, and using zolbetuximab, which is anti-Claudine 18.2, plus chemo versus chemo alone. And again, this was a positive trial. Now, there's other studies. I'm done. There's other studies that have been done for this Claudine 18.2. Remember those. This is another receptor that how to look for it. There is some CAR T cell, but again, the summary of this, novel targets tend to work well, but differently in different disease. No matter what the disease, molecular profiling is critical in GI malignancies. And thank you.
Thank you
I'm on
very much,
time.
Professor. Thank
I'm
you
on
very
time.
much.
I'm on time.